Wow, we couldn't have organized a better 1-2 punch if we had been conscious of doing so. Perhaps we were, Melissa. So, Bev did a very powerfully moving and effective job of making the case for why we're here having this discussion. In the quote, best healthcare system in the world, the experience that Joe and Bev had is unfortunately remains all too common. So it's good that we're here. So I guess, Bev, my question to you is, what's your reaction to what you've heard so far? Are we on the right track? What are we missing? You are the audience for this work.
Okay. I think we have to have a campaign to educate the public. I was actually doing palliative care as a special ed teacher. My colleagues and I were doing this, and I didn't even know it had a name. So everything I wrote about what I was doing. I wrote a letter to the hospital shortly after Joe passed to urge them to do better care. And some of what I read today was in that letter. And my girlfriend read it. She was head of rehab at a facility, and she said, that's palliative care. And I said, well, what's that? And she said, it's what you wrote about. So I think we have to educate the public about the importance of this care, as well as the medical community. Yeah. And I think we're on the right direction.
Yeah. And I'm going to take my prerogative and ask one more question. I think it's interesting, Justin and Tom, how you both addressed the critical importance of communication about what to expect and giving that power back to the patient and family so they can guide what we do. And Justin, you started to get at the failure of advanced care planning as the turnkey solution, which we've been trying to force on people for decades with strikingly minimal impact. So I guess, Tom and Justin, I'd just like you to address that issue, the lack of fit between the standard approach, who do you want to appoint to make decisions for you, have you completed a living will, and the emergent concept of understanding and decision-making that Justin described. Tom, you want to take a crack at that?
Sure. I'm also a healthcare provider. I also have to sign out my inpatient unit up until we closed it a few months ago. I have to sign out to the hospitalists taking care of those patients, whether they want to be coded in the middle of the night or not. So I have a very practical, hands-on approach. I have to know what I should do if somebody's body starts to die, and we hopefully address all those questions beforehand. So while I appreciate the horse before the cart analogy, I'm also a practical person who says, these are the really difficult questions that your healthcare providers have to know. Do you want dialysis? Let's talk for a minute about what dialysis means. Do you want to be on a ventilator for your last days? Because the culture that people learn how to do this is the culture of their own institution. And at University of Washington, one of my postdocs this year, Liz Steng, just published an article at 4 different centers in the UK at Cambridge Hospital. Is basically the physician makes a decision and informs the patient of it. The old paternalistic model. And at the University of Washington in Seattle, it's a shared decision-making model. You start asking the patient, what's important to you? What do you like? What would be important going forward? What's your understanding of your situation? By the 3rd or 4th day, you come to, do you really want to spend your last days on a ventilator or not? Let's discuss the chance of it working. It might be 20% that you'd survive. But with most of the patients I see, their chance of being successfully resuscitated is pretty darn close to 0. And I believe that people have a right to know that if they want to know, and that will help them make a better decision. So we learn those things. And I just read an article that's coming out today, I think, about the rapid rise in appointing durable power of medical attorneys. It's gone from like 40% to 70% of people now have an appointed spokesperson for them. It makes not a bit of difference, not one bit of difference. The only thing that makes a bit of difference is if you've discussed your wishes with your power of attorney and if you have a written living will or a written advance directive. Those things allow people who want resuscitation and dialysis and everything at the end of life to get it, and they protect those who don't. But just having an appointed person makes absolutely no difference. So I'm so tired of hearing my colleagues say, well, we just need to figure out who's the decision maker. That's a start. But then you have to say, have you and your Aunt Maud actually discussed what you would want to happen? Because your surrogate, the person making decisions for you, 50-50 chance of them getting right. In fact, most of the time, they're going to be more aggressive than you yourself would want to be. So on a practical point, I agree that we're putting the polls, their forms, they force us into checking the boxes. That's not ideally the way to do it, but it's the way we have to do it now. And there's so much societal reluctance and patient and family reluctance to do this. Sometimes it's really good to have that form, which in Maryland is mandatory. So I have to discuss these things with people before I send them home with home care. And I don't think that's a bad idea.
I would just say, so I agree with you, Tom, about the importance of the proxy discussing with the patient. In fact, I think, having thought a lot about the mechanism that one gets from advanced care planning to goal concordant care, I think advanced directives, I mean, the data doesn't show that that's the mechanism by which it happens, and we're trying to start to do some work that it's to show that it's the family by which that happens, so the communication that happens. And what I think we do, the first thing I want to say about our intervention, which I think we've seen, is that I think that the discussions that the clinicians have with their patients, and we're testing it in primary care and nephrology and oncology, really provide a model for patients in a very sort of psychotherapeutic sense, a model for patients about how to go home and have these discussions with their own family. And we often hear that in talking with the patients that we're doing our work with now in South Carolina, about how they say, they walk away from this and they say, I have a better sense about how to talk to my family about this now. The second thing I'd say is that having trained now in the hundreds of clinicians and having heard back from many of them, when they don't ask about procedures, somehow magically the procedures seem to drop out of the conversation. People say things like, well, you know, I wouldn't want to go through, I wouldn't want to go in the ICU. I wouldn't want to be resuscitated, sometimes they say. But what it leaves the space open for is understanding what their most important values are, and then we can do what we were trained to do, which is to make recommendations to patients, because that's really what they need. And when health literacy issues are very acute, when people can't understand and we force them to sort of make sense of their care on these very concrete terms that exist in these checkboxes, they feel lost. And when we say to them, what I hear you saying is that your most important goals are to spend the time with your family, and what I know about your illness is that further chemotherapy isn't going to help you. So what I recommend to you is that we do this, or do this, or do this. Is that okay? And I think patients feel very cared for in that setting. So those are my thoughts on that.
Yeah. Thank you. So we're going to turn now to the roundtable for your questions. What you need to do is turn your tent card up if you have questions. And then once the roundtable has been able to articulate their questions, hopefully we'll have time for questions from the audience as well. So, Linda.
Yes, good morning. Thank you for the wonderful panel. Justin, my question is for you, and that has to do with your way of framing health literacy as an emergent kind of quality, which I think has the potential for being very powerful, but it also has the potential of challenging the professions for having some responsibility for improving the health literacy of their patients. So my first question is, what is your evidence that health literacy is emergent rather than a personal characteristic? And then I'll follow with a second question.
Well, I did take it from the Institute of Medicine report. I will say that it was in the sentences following the definition, but I agreed with it wholeheartedly. And I would say that the evidence is not something that I can point to in the literature necessarily, but would be from my own experience, which is that people with poor health literacy know everything they need to know about their goals and values. what they don't know is about how we force them into certain boxes that meet our understanding of clinical care. So what I know as well is that certain clinicians have very difficult times talking about these issues in ways that make sense to patients. One of the patients we had in a focus group just yesterday in South Carolina said, you know what I like about these questions is that it makes the doctor talk like a human. And I really feel that. I feel like these questions sort of bring us back down to earth in a way that is very clinically relevant, because it gives us information that we can translate into something useful. And so I think that when we define health literacy as something someone possesses, we do it very much on our own terms, because they don't. It's almost like when in medicine we say that a patient's family is reasonable. It just means that they agree with us. It's true. And similarly, when we say that they understand something, it means that they understand it how we've expressed it to them or how we expect them to understand it. So that's why I think that health literacy is an emergent phenomenon, and one that really emerges from our interactions with patients as humans is so important, because it's not working the way we're doing it now.
Quick follow-up. You know, I think you're reasonable because you kind of agree with the way I've been trained about communication. But I think it also suggests that other things emerge as well, like goals and values and preferences. And so it's possible to think about that conversation as having a lot of these, producing a lot of changes across the board. So how do you, have you considered that in your formula for how to have a conversation and the implications for that?
Yeah, so one of the things we do with our conversation guide, and again, you have it with you, is there's a checklist on the left, and really there's a big component of this that is setting up the conversation to have with a patient and sort of introducing it in a way that's non-threatening in order to sort of create this safe space. And one of the things we encourage clinicians to say is that no decisions have to be made on the basis of this conversation. We don't want it. And frankly, we're thinking a lot about now what we need to do to think about this in the intensive care unit and the hospital setting, because we want to be able to give guidance to clinicians who do need a decision now about what's going to happen with someone's care. But I would just say that the decisions that do come out when you say, what are you willing to go through, or what abilities are so critical, and someone says, well, I want to breathe on my own, that's something that's critical to me, or I want to be able to eat with my own mouth, then you can say, well, I recommend to you, based on what you've told me, that we not put in a feeding tube, or that when you die, we allow you to die naturally. When you can't breathe on your own, we give you medicine to be comfortable, things like that. Does that address your question? Okay.
Thank you. Wilma.
Thank you very much for the wonderful presentations. And I agree with one of the things Diane mentioned. I would hear, oh, we were called 2 months, 4 months, and all that, and I'm thinking, oh, Mother of God, should have been called earlier. I'm just saying. But anyway, my question is, if I heard from Thomas, regarding the communication about the prognosis, and the within some groups they had less prognostic awareness than others. And then Justin touched on some issues regarding the African American communities. So I'm wondering what considerations have been made for groups, for patients whose primary language is not English, and also our deaf and hard of hearing community, or for the caregivers and the family when the patient is English speaking to the best of their ability under these situations, but the family, they may access their emotions in a language other than English. So I'm just curious about that.
Well, it's not just cancer. We got called to see recently a person with liver failure, and went in and had the discussion with them, and they said, well, I understand I'm really pretty sick. Can you tell me how sick I am, and how much time have I got? And nurse practitioner did a wonderful job of explaining that no one can predict with certainty, but we can give hours to days, days to weeks, weeks to months, many months to years. And it turns out physicians are really good at that. we are really good at prognosticating within that realm. Came back to the office, and we got this frantic text page from the house staff on the team. Family says the patient doesn't want to know. Don't tell her. So what we've always learned to do in every culture is to ask, what's your understanding of the situation? How do you like to get medical information? I mean, we've got projects going in Belize and Tajikistan, in Saudi Arabia with Rob Razak and myself, and the cultures are very different. And in Tajikistan, I've been there where the surgeon comes out having operated on somebody for inoperable gastric cancer and tells the man there, you had an ulcer, take these medicines, everything will be okay. Comes outside and tells the family he's got weeks to live. You walk in the room, and chances are probably 50-50 that the person's going to say, what's going on with me? Tell me everything, or not. And what we've learned is always ask the questions, how do you like to get medical information? What's your understanding of your situation? And giving people a couple of simple tools like that is really important. Having a script to start these conversations is really key. Works with house staff. I think Amanda would probably say it's been helpful for her as a medical student. You got to have those scripts. For culture in Baltimore, it's a very much divided city. I've only been there 3.5 years. I've been accused of experimenting on people's loved ones more in 3 years than in 28 years in practicing in Richmond. But again, you just have to ask, how do you like to get medical information? What's your understanding of your situation? And don't make any assumptions. You never make any assumptions about what people want to know. Does that answer your question?
Yeah. Margaret.
Yeah, I want to thank you all for your enlightening and insightful presentations as well. I'm a pulmonologist, so I've dealt with a lot of end-stage COPD and diagnosed a lot of lung cancers, and I really have a comment that I would like your comments on. Bev, what struck me from your presentation was there was no continuity of care. And when I diagnosed a lung cancer patient, for example, and I'd often have to refer them for radiotherapy or chemotherapy or whatever, I took the time to follow up with them and to ask those questions. And the reason why is that I felt, and I might not be right, but that they're really only going to talk to somebody about these issues if they know that person. And with all these other people coming in, like, can you really have the deep conversation with somebody that you don't know? Maybe you can, maybe you can't. But I felt that it was really important. But when I would always communicate back to the referring physician, and so often I would get the answer, well, you follow up with them because I don't have the time and I'm not paid for it anyhow. And I just would like to know your perspective on that. Do you encounter it? Do you see it? Or do you think it's valid?
You're speaking to me? In our case, I mean, the system didn't work at all. Each doctor that we went to just dropped the ball. I want to talk for just a second. There were 2 doctors who really tried to help us. One was Dr. Pitt from the University of Indiana, who tried to find us an oncologist in upstate New York. So God bless him and his staff. They took the time to look at his tests and everything like that. But in rural upstate New York, and unfortunately at Albany Med, where Joe wound up, there just was no coordination of care whatsoever. And so that is the key to me, is coordination of care.
Tom, you wanted to?
Addressing the issue of who should have these conversations, it does not have to be the oncologist or the cardiologist, it should be somebody though. If your primary care physician stays involved, you're twice as likely to get the care that you want, based on studies done in Montreal. Most of the time, the primary care person gets dropped or drops out him or herself. Besides having the functional status as a mandatory thing in EPIC, I would like to see, have you asked the patient who their primary care physician is, and have you communicated with them and added them to the care team before you proceed any further in documenting your note? I can teach anybody in 5 minutes how to do a one-page summary to all the care team members on EPIC or Cerner if that's important. We did a study where we interviewed 85 consecutive people coming into the oncology ward. 10 of them were so sick they couldn't talk. What percentage of them had advanced directives? Out of 75, it was 40%. A little less in African Americans, a little higher in Caucasian Americans, but close to 40%. The oncologist was aware of that 5 out of 75 times. The oncologist had brought it up 2 out of 75 times, and most of these patients had an average survival of about 3 months. And we asked the question, when you're being admitted to the hospital, do you think it's important to have a discussion about advanced directives? What do you think people said? 90% said yes. Are you comfortable discussing this with the team that's admitting you to the hospital that you've never met before? What do you think the answer was? 90% said yes. Yes. Would you like to discuss this with your oncologist? No. What? What? WT? 23% wanted to discuss advanced directives and advanced care planning with their treating oncologist. It's very paradoxical, but it's a second study to show exactly the same thing. So it turns out for some patients and families, it's going to be a lot easier for them to discuss what's going to happen to them with you as a pulmonologist before you intubate them for their lung cancer on third-line chemotherapy than it is for me as their oncologist. Does that get me off the hook for having these discussions? No. Does it mean that anybody with an interest and has the ability to pull up a chair, sit down and say, what's your understanding of your situation? How do you like to get medical? Anybody can have those conversations. And I don't think a lot of doctors are wired this way. If you look at palliative care, it's much more on a nursing model. It's much more on a communication, psychologist, social work model. We do a lot of interesting medical stuff, but it does not have to be the oncologist. Some of the practices in Texas Oncology, they have advanced care planning discussions up to over 80%. And they've got hospice for lung cancer patients close to 90% with up to 2 months in hospice. Who'd have thunk that? And what they've done is they've made it best practice for somebody in the practice to discuss advanced care planning with somebody on the first 3 visits, not the last 3. And you get dinged by Texas Oncology or US Oncology if you don't do that. So that forces practices to say, okay, Dr. Smith is the oncologist, well, we better get somebody else to do this. We can have the social worker or the financial counselor. We can have somebody to discuss and use, meaning if you would make those tools immediately available to the universe, US Oncology could put them right in place today because they're doing this on a regular basis.
So our tools are available to the universe. But I think, what I would say, so we have this large randomized controlled trial going on at the Dana-Farber Cancer Institute with all oncologists. And I believe that we're going to be able to say next year that these oncologists feel better about their job as doctors when they're able to have these conversations with people. And we know that burnout exists because people don't feel competent in taking care of these solutions. I would say that, so we've done these interviews with African Americans in the South about these conversations specifically and who they think would be best person to have them. And the results are kind of mixed. I mean, it's funny because the experts, the academics who we interviewed and the clinicians really felt like the patient's primary care doctor would be the one. And the patients who we just spoke with yesterday said, we think that the specialist physician, and it kind of reflects the care that we give in this country where the specialists kind of take over for the primary care doctor in a lot of settings. It's certainly the case at Dana-Farber. It's not the case everywhere, but these oncologists feel incredibly invested in their patients, and their care team feels that they, in some ways, are the primary medical home for these patients, even if it wasn't that way before. So I think whoever cares the most in some ways and feels that they have the ability to do this conversation well is the one that should do it. I shouldn't say cares the most. That's not fair. People care, but really feel comfortable doing it. So
yeah, so I just have to weigh in on this because Dr. C, Jenny's doctor, was offering futile treatment because he cared about her so much, and he had no alternative. He didn't have the tattoo on his wrist. He did not know what to do. So it wouldn't have helped to have someone else have this discussion. So I don't think we get the shortcut in a way of, as long as doctors feel that by not doing what they were trained to do, they're abandoning, they'll keep doing what they were trained to do. Because it is emotional. It's not technical. It is about the relationship. So I have to say, I don't think we're going to get that easy out of just assigning the job to someone else. Do we have time for one more? One more. Ruth?
So thank you, guys. I'm sure this could go on and on. I just want to push you for 1 minute on health literacy very specifically. And Justin, I think you and your generation are the hope of the future, and me and everybody my age and near my age, we've done a lot for you to, we built a lot of stuff that y'all can work on. So go get them. That would be my bottom line to you and those of the next generation. So anything we can do to lean out and let you lean in, let us know what we can do. So my question is very specific to, and I know Paul, if you're on the phone, I hope, Shivey, and Cindy and some others worked on sort of looking at attributes of health literate healthcare organizations. And I'm thinking about, really this intersection of health literacy with palliative care and these really tough decisions around end of life, which we've never gotten them right, and I don't know if we ever will, but I think we should keep working on them. So big issues, but I'm trying to drill down. And I get that communication and communicating and all its dimensions are sitting right there. And some of those issues relate specifically to health literacy, and some go way beyond to all those other really tough things that we emote about and feel so strongly about and respect. But one of the, so I get language, I get communication, I get content materials and making them easy to understand, navigate, use, that kind of stuff. And the other one I didn't hear mentioned specifically, and I'm putting this on the record, and I'm asking you, cost transparency, and how issues related to people's ability to understand and navigate what things actually cost enter into decision makings in a zone where there are a lot of charges and there are a lot of cost. And that's on the horizon for healthcare and for health, with bankruptcy, personal bankruptcy being another number one cause of health-related debts, medical debt being a number one cause of personal bankruptcy. Where are we with looking at that issue related to cost and how people think about it, if it is an issue of health literacy for shared decision-making, to understand how much debt you're going to have, what it's going to mean, what it's going to feel like it, who's inside that zone, and does it belong there?
There are absolutely no studies of people of varying literacy and health literacy skills being given their actual cost for their treatment. In fact, up until last month when we published an article on it, there were no costs, there were no studies where people were actually given their own costs about their treatment for cancer, but we did it. We did it with 93% of people wanted to know what their treatment was going to cost. And we were looking at, does this destroy the patient-physician relationship? Because that was, can't bring that up. It'll destroy the patient-physician relationship, as if that's something that's sacrosanct when we spend 2 minutes in the room. It turns out it doesn't. 93% of people wanted to know. The others were too sick to answer the question. And when we gave people what their monthly costs would be to be on treatments and showed them the different range, no conflict whatsoever. And when we asked the question, if your copays are going to go up, which they are, do you want to know the cost of treatment? The answer was essentially 100% said yes. And having done this with people of varying literacy and health literacy and background skills for a long time now, because people will ask me about how much is this going to cost? Can I afford it? What's my 20% copay? You can make this understandable. You're going to have to search at your own institution to find out what the costs are. And then you're going to have to get it in an easy to understand graphic way. It's really hard to get those costs. The last Institute of Medicine report on Medicare, a system in crisis, which I was on, said every health system should have essentially the cost posted at the door. I can't get Hopkins to do that.
Well, they don't even know what they are.
Well, I disagree that we don't know what the costs are. We can always give you an average and say it's going to be 10% off depending on who your insurer is and what we're going to charge them. But I can tell you what the cost of 6 cycles of Rituxan CHOP is. US Oncology does that. They did it November a year and a half ago. And every time you walk in the office when you're going to start a plan of treatment, they tell you what the plan of treatment's going to cost. And they have financial counselors there to help you figure out if you can afford it and whether you can pay for it or not. And that's proof positive to me that we can do this no matter who you are.
Can I just say that the people, just quickly, can I just say that the people for whom we worry most about health literacy don't have the money to pay for anything. And they're not worried about costs. They're just worried about staying alive. The other thing is that with health literacy issues comes health numeracy issues, and so talking about costs of care is very complex. And as a group of people some of whom have a mortgage without a house related to educational debt, we're probably not the best equipped to talk about costs of care in relation to benefits. So I would just say that I'm not sure how important it is to talk about costs of care with people. I think the changes of care that reduce costs when we elicit goals and values are patient-driven, not system-driven. And I think that's the most important kind of cost savings.
I think it's going to hit the fan in the next year with some things like pembrolizumab at 10 milligrams per kilogram costing $150,000 a month. People are going to want to know, what's my copay for that? Is it going to be covered at all? Yes, it works. 25% of people respond. Average response time is, it lasts 3 to 4 months. That's very different than talking about curative therapy for Hodgkin's disease. We're talking about a palliative third-line chemotherapy for lung cancer, which can work really well for some people, but we're going to have these cost discussions right up front with people. No ifs, ands, or buts about it.
So, Ruth, that's a question that obviously we can spend another half hour on because it is a core question related to the issues we've discussed. Diane and Beverly and Tom and Justin, I really want to thank you for excellent presentations this morning. I'm sure everybody in the audience more than appreciates the time and effort you put forward. Just a quick moment, and we'll go into this a little bit more later. But what I heard this morning are really distinctive features that reflect professionalism and should be an integral part of every healthcare team member's training and ability, not only in palliative care situations, but in general as we treat patients going forward. The issue of what is most important to you, or the physician side, I don't want the patient to think I'm abandoning her. The issue of trust and competency that Justin mentioned. The coordination of care, person and family-centered care, shared decision-making, how it is heard and how it is said. I think these are transcending cross-cutting issues that reflect importance in palliative care, but reflect importance in the delivery of care to patients in general. And these are issues that we may couch in system issues, cultural issues, but it really has to do with organizational professionalism and the way we treat patients going forward in every aspect of the doctor-patient relationship. Well, with that said, by the way, I also want to thank the others who have been extremely helpful in putting this meeting together. Lila Hernandez, thank you, Lila, as always. Melissa French and Emily, thank you always. Again, I don't know where Melissa is at the moment. There she is in the back. Thank you very much. And without them, obviously, without their expertise, we wouldn't have the facility we had this morning in dealing with these very, very difficult issues. We will now have a 15-minute break. I think many of you will need that break. And we'll reconvene and begin our next session at promptly 10:55. Thank you.